Welcome to the Deep Dive, where we take complex information, strip away the noise, and distill the most important insights for you. Today, we're embarking on a pretty crucial deep dive into the world of vascular surgery and limb preservation. We're tackling the nuances of classifying threatened lower extremities, a challenge that profoundly impacts patient outcomes, research, and treatment strategies. Our source material for this deep dive is a foundational document from the Society for Vascular Surgery detailing their new lower extremity threatened limb classification system.
Indeed, and this is particularly relevant for you, our specialist clinician listener. We're going to unravel how this innovative system aims to redefine patient assessment and, importantly, the comparison of various therapies. So, our roadmap today. First, we'll navigate the historical context. Look at the limitations of previous classification systems. Why did we need a change? Then, we'll thoroughly unpack the new Society for Vascular Surgery wound, ischemia, and foot infection, or WIFI classification system. We'll dive into the meticulous details of its wound, ischemia, and infection grading. And finally, we'll explore its real-world clinical application. Things like risk stratification, the anticipated benefit of revascularization, and where this framework might be heading. This truly sets a new standard for defining disease burden in chronic limb ischemia.
Okay, let's unpack this then. For decades, clinicians have grappled with classifying critical limb ischemia, a term first defined way back in 1982. But from your perspective, what's one key area where those older systems truly fell apart, making meaningful comparisons almost impossible, especially with today's patient populations?
Well, what's fascinating, really, is that the original 1982 definition of critical limb ischemia was actually quite narrow. It was specifically meant to identify patients whose primary limb threat was chronic ischemia, purely ischemia. It even suggested excluding or separately analyzing patients with diabetes. Why? Because their clinical picture is just so much more varied. Neuropathy, ischemia, sepsis, all playing a role. Now, the praline systems back then, Fontaine and Rutherford, they broadly categorized patients into ischemic rest pain or tissue loss. Simple enough. But, fast forward 40 years. The landscape is fundamentally different. We've got this global rise in diabetes and rapidly expanding techniques for revascularization. The problem? Well, those older systems simply couldn't keep up. Their application became overly liberal, stretched far beyond their initial narrow scope. And that made it incredibly difficult to truly measure and compare outcomes of different treatments.
Right, it's clear the old system just couldn't keep pace. So, beyond those big demographic shifts, what were the most glaring weaknesses of those older classifications, especially when we talk about patients with diabetes?
Yeah, the core issue was their inability to assess and grade the full spectrum of factors that influence limb loss. It wasn't just about blood flow. For a patient with diabetes, limb threat is truly multifactorial. Perfusion is critical, yes, absolutely. But so are the extent of the wound and the severity of any infection. The older systems just didn't capture this complexity. If you look back at systems like Rutherford or Fontaine, sure, they had categories for rest pain, ulcer, gangrene, but they lacked the necessary granularity for wound extent. How bad is the wound, really? And they completely omitted infection as a graded trigger. Just wasn't there. Similarly, many diabetic foot ulcer classifications, like the University of Texas or Wagner systems, they might have graded wounds, but they only offered a binary yes or no for ischemia, or they completely overlooked infection severity altogether. Even the Infectious Disease Society of America system, which is excellent for infection, didn't address wound type or perfusion status. Essentially, none of these systems, in isolation, were comprehensive enough to truly stratify patients or allow for accurate comparison of outcomes across different centers or treatment approaches. They were too narrowly focused. It's like trying to describe a complex painting by only looking at a single color.
That's a really powerful analogy. And it raises an important question, doesn't it? What about the very concept of critical limb ischemia itself? Does it still hold true that without revascularization, a limb is inevitably lost?
That's a crucial point, and it's been seriously reevaluated. The answer is increasingly clear. No, not inevitably. The term critical limb ischemia implies this sort of rigid cutoff, right? Below this line, intervention is mandatory to save the limb. But real-world data really challenges this idea. Consider trials like Circulase. Even in the placebo arm, these are patients with severe ischemia. Mind you, the amputation rate at 6 months was only 13%. And importantly, untreatable infection, not just ischemia, was often the driving reason for amputation. Or look at Marston's work. It showed that a significant number of patients with severe limb ischemia actually achieved wound healing without revascularization. Their amputation rates were around 19% at 6 months. A more recent study by Elgziri further reinforced this, showing that 50% of diabetic patients with ischemic foot ulcers who were not revascularized still healed primarily with wound care or maybe a minor amputation. So these findings really underscore that limb outcome is multifactorial. It's not just about blood flow. Wound severity and infection play a massive role, and a limb is inevitably lost solely due to ischemia. The traditional definition was just too rigid for the complex reality we see in these patients.
So, if I'm understanding this correctly, we were essentially trying to fit this, multi-dimensional problem into a very flat two-dimensional box. And the cracks really started showing with the rise of diabetes. Is that a fair summary?
That's exactly it. A perfect summary. We desperately needed a system that embraces the multidimensional nature of limb threat.
Okay, let's put this into a clinical context for you listening. Imagine this board-style question. A 58-year-old male with long-standing diabetes presents with a non-healing foot ulcer. You note that the original 1982 definition of critical limb ischemia stipulated the exclusion of diabetic patients. Which of the following is the primary reason why the original critical limb ischemia definition and older systems like Fontaine and Rutherford became inadequate for modern clinical practice, especially in patients like this? A. They overemphasized arterial anatomy and completely ignored wound characteristics. B. They failed to consider the dramatic rise in diabetes incidence and the critical impact of infection on limb outcomes. C. They exclusively focused on lower extremity pain and excluded any form of tissue loss. D. They did not provide specific hemodynamic cutoff values, leading to inconsistent diagnoses. Pause. All right, the correct answer here is B. While older systems definitely had other limitations, their fundamental inadequacy for modern practice, as the Society for Vascular Surgery highlights, really stems from that global diabetes epidemic and their failure to adequately account for infection as a major determinant of limb threat, right alongside ischemia and wound extent. So, after wrestling with these outdated definitions for so long, how did the Society for Vascular Surgery actually tackle this enormous challenge? What was their core philosophy in building a new system, one that finally addresses these complexities?
Well, this new framework, the Society for Vascular Surgery Lower Extremity Threatened Limb Classification System, it represents a pretty dramatic shift in focus. It's built on three major factors: wound, ischemia, and foot infection, hence WIFI. The core philosophy was really to move away from that binary critical definition. Instead, the goal was to define the burden of disease. Think of it like the tumor node metastasis system used for cancer staging. That's the analogy they use. It recognizes that limb ischemia exists on a gradual spectrum, not some sharp cutoff point. Wound healing, therefore, isn't just about blood flow. It's a complex interplay of the extent and depth of the wound, the degree of ischemia, and the presence and severity of infection. Now, it's important to stress this system isn't meant to dictate treatment. That's not its job. Rather, it's designed to provide a precise, standardized description of the disease state. Why? To allow for accurate outcomes, assessments, and meaningful comparisons of different therapies. It's really about speaking the same language, finally, when we talk about these complex patients.
That's incredibly detailed, and I like the analogy to cancer staging. It makes a lot of sense. So the WIFI system is fundamentally built on grading these three components: wound, ischemia, infection, from 0 to 3. None, mild, moderate, and severe. Let's dive into the specifics of each grading component, starting with wounds. How are wounds categorized in this new system? What's the breakdown?
Absolutely. The real strength of WIFI lies in its granularity. Let's look at wound grades. We stratify from grade 0 through grade 3, focusing on size, depth, severity, and also the anticipated difficulty in healing. So, grade 0, simple, no wound. This is typically your patient presenting with ischemic rest pain only. Grade 1, this is minor tissue loss. Think small, shallow ulcers. Maybe a digital ulcer that you expect to heal with simple interventions, perhaps a single digital amputation or just basic skin coverage. Grade 2, now we're getting more advanced. This is considered major tissue loss. We're talking deeper ulcers with exposed bone, joint, or tendon, or perhaps gangrene that's limited just to the digits. These are considered salvageable, but they demand more complex management. Maybe multiple digital amputations or a standard transmetatarsal amputation. Grade 3, this is extensive tissue loss. Really significant wounds. These are massive, deep ulcers involving the forefoot, midfoot, or deep heel ulcers hitting the calcaneus. Or extensive gangrene. These are those challenging, often requiring complex foot reconstruction or non-traditional amputations, like a chopart or Liesfranc.
Critically, depth takes priority over size in this classification, although measuring wounds is still recommended, of course. And it explicitly excludes advanced gangrene, where saving a functional foot just isn't possible.
Okay, that provides a very clear spectrum for wounds. Very logical. Now, for the ischemia component, how does the WIFI system give us that more granular assessment compared to the older methods, especially thinking about the issues with ankle brachial index in certain patients?
Right. For ischemia, again, we're talking about a graded spectrum, not a rigid cutoff. Scaled 0 to 3, based on hemodynamic parameters quantifying perfusion. Grade 0, no or very mild ischemia. Think an ankle brachial index of 0.80 or greater. Or a toe pressure, TP, or transcutaneous oximetry, TCPO2, of 60 millimeters of mercury or greater. These patients generally aren't likely to need revascularization. Then at the other end, grade 3, this is severe ischemia, defined as an ankle brachial index less than 0.4, or critically a toe pressure or TCPO2 less than 30 millimeters of mercury. This grade strongly suggests revascularization is needed and carries a high amputation risk. Grades 1 and 2 naturally fall in between. They reflect mild and moderate ischemia respectively, with gradually decreasing pressures. Now here's the really critical takeaway, something you absolutely must do. Measure toe pressure or TCPO2 in patients with diabetes or the elderly. Why? Because medial calcinosis, hardening of the arteries, can give you a falsely elevated or sometimes incompressible ankle brachial index. It looks better than it is.
Toe pressure is much less susceptible to these calcification artifacts. It gives a more accurate picture of actual foot perfusion. It's mandatory in all patients with diabetes according to the guidelines. And if the ankle brachial index and toe pressure measurements give you different grades, toe pressure dictates the ischemia grade. It's the primary determinant.
Got it. Toe pressure is key, especially in diabetics. Okay, and finally, the foot infection component. You mentioned earlier how previous systems often overlooked this or treated it pretty superficially. How does WIFI address the crucial role of infection and limb threat?
Yeah, the foot infection grades, also 0 to 3, are a direct adaptation of well-established classifications. They leaned heavily on the Infectious Diseases Society of America, or IDSA, guidelines, and the International Working Group on the Diabetic Foot, the IWGDF, classifications. Specifically, it mirrors the infection part of their PETA system that considers perfusion, extent, depth, infection, and sensation. Using established systems ensures a consistent and validated approach. And infection is a huge player here. It dramatically increases amputation risk, it can often be the trigger for amputation, and it even increases the local tissue's need for blood flow by boosting metabolic activity and causing microthrombosis, tiny clots. So the grades. Grade 0, simple, no symptoms or signs of infection. Grade 1, mild. You need at least 2 local signs. Things like local swelling, erythema, redness between 0.5 and 2 centimeters around the ulcer, local tenderness, warmth, or purulent discharge. But it's confined to the skin and subcutaneous tissue. No deeper involvement, no systemic signs, and you've got to rule out other inflammatory causes like trauma or gout here. Grade 2, moderate. This involves more extensive local infection. Erythema greater than 2 centimeters, or involvement of structures deeper than skin and subcutaneous tissues. Think abscess, osteomyelitis, septic arthritis, or fasciitis. But importantly, still no systemic inflammatory response signs. Grade 3, severe. This is the critical alarm bell. It means the local infection is causing a systemic inflammatory response syndrome, or SIRS, manifested by 2 or more signs like a temperature over 38 degrees Celsius or under 36, heart rate over 90, respiratory rate over 20, or abnormal white blood cell counts. This isn't just a local problem anymore. It's a body-wide crisis driven by the limb infection, and it's associated with a very, very high risk of early amputation.
Okay, let me try a quick micro recap for that section. The WIFI system is a major step forward. It moves beyond that simplistic critical limb ischemia label. Instead, it gives us this comprehensive graded assessment of the 3 key factors: wound, ischemia, and foot infection. This allows for a much more accurate, more nuanced understanding of the threat to the limb, kind of like cancer staging. And the goal is to provide a standardized framework for outcomes analysis, right?
Exactly right, a common language.
Okay, let's consider another practical scenario for you, the clinician listening. A 65-year-old patient with diabetes presents with a 2-centimeter plantar foot ulcer with exposed tendon. Their toe pressure is 35 millimeters of mercury. There is surrounding erythema of 3 centimeters plus purulent discharge, but importantly, no signs of systemic inflammatory response syndrome. How would this patient be classified using the Society for Vascular Surgery wound, ischemia, and foot infection system? A, wound 1, ischemia 1, foot infection 1. B, wound 2, ischemia 2, foot infection 2. C, wound 3, ischemia 3, foot infection 3. D, wound 2, ischemia 3, foot infection 2. Pause. All right, the correct answer here is B. Let's break that down quickly. The exposed tendon means deeper tissue involvement, making it a wound grade 2. A toe pressure of 35 millimeters of mercury falls squarely into the ischemia grade 2 category. That's between 30 and 39. And the erythema greater than 2 centimeters with purulent discharge and deeper tissue involvement, but crucially no systemic signs, classifies this as a foot infection grade 2. So, wound 2, ischemia 2, foot infection 2. or WIFI 222. So I've got the grading system down. What does this all mean for real-world clinical application? How does this sophisticated grading system translate into assessing, say, amputation risk and the potential benefit of revascularization for individual patients?
Right, this is where it gets practical. The system is designed for a broad spectrum of patients with lower extremity atherosclerotic occlusive disease. That includes ischemic rest pain, diabetic foot ulcers, non-healing ulcers lasting at least 2 weeks, or gangrene. It's important to remember the exclusions, though. It's not for pure venous ulcers, acute limb ischemia like from an embolus acute trash foot, or non-atherosclerotic causes like vasculitis or Berger's disease. Now, the beauty is, with 4 grades for each component, 0 to 3, you get 64 theoretically possible WIFI combinations or classes. To figure out how useful this is clinically, they conducted a Delphi consensus process. They got 12 expert vascular surgeons together and asked them 2 core questions for each of those 64 combinations. First, what's the perceived risk of amputation at 1 year if you just treat medically? And second, what's the perceived benefit from or need for revascularization for that combination, assuming infection is controlled, of course. This exercise was really designed to define stages of disease that could be useful for clinical decision-making and, crucially, for designing future studies.
Okay, let's visualize Table 4, Part A from the SVS document. This maps the estimated risk of amputation at 1 year for each combination. How does this matrix guide our understanding of a patient's prognosis without intervention?
Yeah, Table 4, Part A is really insightful. It shows the expert consensus on the estimated 1-year risk of major limb amputation with medical therapy alone. It's stratified into 4 clinical stages. Stage 1, very low risk. Stage 2, low risk. Stage 3, moderate risk. And Stage 4, high risk. What immediately stands out is the clear trend. The risk of amputation generally increases as you move down and to the right within that matrix. What does that mean? Increasing severity in any of the components, wound, ischemia, or foot infection, escalates the threat to the limb. A key insight this reinforces is that even lesser grades of ischemia, grades 1 or 2 below what was traditionally called critical, contribute significantly to amputation risk when you also have complex wounds or more severe infection. It's the combination that matters. So this table really offers a powerful predictive assessment. It helps understand the natural history of the limb without revascularization. And the expert agreement on this staging, the inter-rater reliability, was impressively high. They used intra-class correlation coefficients, and they were excellent. 0.81 for single measures, 0.98 for average. Really strong consensus.
Okay, strong agreement on risk. Now, what about Table 4, Part B? This looks at the benefit of revascularization. Does it just mirror the amputation risk? Or is it telling us something different?
No, not at all a mirror image, and this is a really crucial distinction to grasp. Table 4, Part B, specifically estimates the likelihood of benefit from, or maybe better put, the requirement for revascularization. Again, assuming any infection is controlled first. This is a distinct assessment from just the risk of amputation. Why? Well, think about it. A large, complex wound with severe infection might unfortunately lead to amputation, even if there's no significant ischemia. In that case, revascularization might offer little benefit in isolation for limb salvage itself. Conversely, a minor wound with mild or moderate ischemia might heal perfectly well with just good wound care and offloading. No revascularization needed. So this table is also classified into 4 groups: very low, low, moderate, and high benefit from revascularization. You'll notice, for instance, that the 16 possible combinations where ischemia is grade 0, meaning good perfusion, are generally seen as unlikely to require revascularization. Makes sense, right? Now, for patients in ischemia, grades 1 and 2 often suffering from what you might call situational ischemia, where blood flows okay at rest, but not enough for healing. The likelihood that revascularization will be required increases dramatically as the wound complexity and infection severity go up. And the ischemia grade 3 category, the severe ischemia group, revascularization might speed healing even for small wounds without infection. But it becomes likely mandatory for wound grades 2 and 3 patients, especially if there's any infection present. So this table is incredibly informative for figuring out if a patient truly needs revascularization and how much benefit it's likely to provide for healing. The agreement here was also quite acceptable, with intra-class correlations of 0.76 and 0.97.
Okay, that distinction between risk and benefit is really important. Let's look at some real-world applications now to solidify our understanding. Can you walk us through a couple of clinical examples, maybe using tables 3 and 5 from the document, just to see how WIFI is applied and highlights these nuances?
Certainly. Let's consider 2 distinct examples to illustrate the power of WIFI. First, imagine a patient presenting with ischemic rest pain only. That's their chief complaint. No wounds, no signs of infection. But their ankle brachial index is critically low, say 0.30. Using the system, this patient will be classified as wound 0, ischemia 3, foot infection 0, or WIFI 030. Now, according to that Delphi consensus in Table 4, Part A, their clinical stage for one-year amputation risk is actually low, stage 2. However, if you look at Table 4, Part B, the anticipated benefit of revascularization for this patient is rated as high. So this highlights that severe ischemia alone, even without tissue loss yet, still strongly warrants intervention to prevent future problems and relieve symptoms.
Okay, so low amputation risk currently, but high benefit from fixing the flow. Makes sense. What about another example?
Right, now let's consider a different scenario. A 44-year-old woman, maybe without a previous diagnosis of diabetes, who presents really sick with systemic sepsis. She has a high fever, 39.5 degrees Celsius. Her white blood cell count is sky high at 26,000. Blood glucose is 600. And on her foot, she has a large 6-centimeter full thickness wound on the plantar aspect of the forefoot with crepitus, that crackling sound suggesting gas. But her dorsalis pedis pulse is palpable. Maybe her ankle brachial index is normal, say 1.08. How do we classify her? She'd be wound 2 because of the extensive deep wound, ischemia 0 because her perfusion is actually normal, and foot infection 3 due to that systemic inflammatory response to the sepsis. So WIFI 203. Now, her clinical stage for amputation risk, Table 4A, is stage 4, high risk. That makes sense given the sepsis and wound. But here's the crucial part. The anticipated benefit of revascularization, Table 4B for her, is rated as low. Why? Because the primary immediate threat isn't ischemia, it's the overwhelming systemic infection. Controlling that infection surgically and medically takes absolute precedence. Revascularization isn't the priority here, and might not even be helpful. This WIFI example beautifully demonstrates how the system helps prioritize intervention based on the true drivers of limb threat in that specific patient, not just automatically defaulting to fixing blood flow. And one more really important point, the document emphasizes reclassifying the limb at the time you're actually planning the revascularization, if you decide it's needed. This is because things can change. Controlling sepsis with antibiotics or performing an initial foot debridement can alter the wound or infection grade from the initial presentation. This reclassification process, which they detail in Table 5, is kind of like restaging that occurs in cancer treatment after initial therapy. For instance, a small superficial wound, initially maybe wound grade 1, could become a wound grade 2 or 3 after surgical debridement removes non-viable tissue, revealing the true extent right before you plan the revascularization. This dynamic assessment ensures the most accurate picture of the disease burden is used for definitive treatment planning.
That's incredibly powerful, showing how WIFI moves beyond just focusing on revascularization and considers the whole clinical picture, even dynamically. Okay, let me try to mega recap this entire deep dive for everyone listening. The Society for Vascular Surgery Wound, Ischemia, and Foot Infection WIFI classification system is a comprehensive, graded framework. It's designed to accurately define the disease burden of a threatened lower extremity. By integrating the severity of the wound, the degree of ischemia, and the presence and severity of infection, it really moves beyond the limitations of older, often binary systems. It offers a much more nuanced, patient-specific assessment of both the risk of amputation and the potential benefit from revascularization. The aim is to provide a consistent language for patient stratification, much like the tumor node metastase system does for cancer. This should pave the way for more meaningful outcomes analysis and improved clinical trial design in this very complex patient population. This framework truly reflects the multifactorial nature of limb threat, acknowledging that ischemia is just one critical component among a triad of factors driving the risk of limb loss. Did I capture that? Okay.
You absolutely nailed it. That's the essence of WIFI.
Great. All right, here is a final board-style question for your consideration, clinician. A 70-year-old patient presents with a deep heel ulcer involving the calcaneus. They also have gangrene of 2 toes and a foot infection that's causing systemic inflammatory response syndrome. They're septic. Her toe pressure is measured at 25 millimeters of mercury. Based on the Society for Vascular Surgery Wound, Ischemia, and Foot Infection System, what would be the most likely clinical stage representing her 1-year amputation risk? A, stage 1, very low risk. B, stage 2, low risk. C, stage 3, moderate risk. D, stage 4, high risk. Pause. Okay, the correct answer here is D, stage 4, high risk. Let's quickly analyze why. A deep heel ulcer involving the calcaneus plus gangrene extending into the foot clearly indicates a wound grade 3, extensive tissue loss. A toe pressure of 25 millimeters of mercury signifies severe ischemia, placing her in ischemia grade 3, less than 30. And a foot infection causing systemic inflammatory response syndrome is, by definition, a foot infection grade 3, severe. So we have a WIFI 333 combination. If you cross-reference that in Table 4, Part A, the amputation risk table, you'll consistently find it falls squarely into clinical stage 4, signifying a high risk of major limb amputation at 1 year. This deep dive truly highlighted the complexity and really the evolution in understanding limb threat. The WIFI system offers such a powerful, multidimensional lens to view these challenging cases. But what's the next frontier for this framework? You touched on future directions earlier. Can you elaborate a bit more on how integrating things like a comorbidity index and maybe a simpler anatomic classification will truly revolutionize our ability to select the best therapy, and maybe move beyond just limb salvage to encompass functional outcomes too?
Yeah, absolutely. If we connect this to the bigger picture, while the WIFI system itself is a transformative step in defining the limb severity, it's really designed or envisioned to be part of an even more comprehensive approach. The authors explicitly talk about a future where WIFI is integrated with 2 other key components. First, a refined comorbidity index to assess the patient's overall risk factors. They suggest drawing from robust studies like the PREVENT-3 trial data or the EuroDial study on diabetic foot complications to build this index. So how sick is the patient overall? Second, a new, simpler anatomic classification system for the arterial disease itself. How complex is the blockage pattern? This needs to directly correlate with outcomes after different types of revascularization, like open bypass or endovascular therapy. So imagine a 3-dimensional matrix for every single patient. You're precisely mapping 1. Limb severity using WIFI, 2. Individual patient risk using this validated comorbidity index, and 3. The anatomic complexity of their arterial disease. This integrated approach, they believe, promises to facilitate even better clinical trial designs.
You can stratify patients much more precisely. Ultimately, this should lead to truly evidence-based care and, critically, improved functional, patient-centered outcomes, moving beyond just saving the limb on paper to ensuring a good quality of life for the patient afterward. So it really raises an important question for you, the listener. How will this integrated multidimensional stratification potentially reshape your own approach to patient selection and treatment planning in the coming years? It's something to think about.
A truly insightful question for our listeners to ponder as they integrate WIFI into their practice. That's all the time we have for this deep dive. Thank you so much for joining us today. We hope you feel more informed and ready to apply these insights. Until next time.